Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athlete trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this week's episode, we are going to be talking about something that I'm pretty sure is the basis of everything we do. And that is pain.
I think you're right. I think it is kind of the basis of everything we do.
Right? At its basic level, we treat people that come in because of pain.
Or, if they're not in pain, they have movement patterns that are avoiding pain.
Ooh, yes. And that's going to be in this episode.
Huh.
Look at that. That
was
a
little sneak peek.
Yeah, I was going to say a little preview.
And I didn't even know that.
Yeah.
This is a CEU, so if you're listening to it as it comes out, it is free. Thank you to Clinically Pressed and Athletic Training Chat. Thank you so much for hosting our CEUs. So make sure you check the show notes for the link for the quiz and the course evaluation, and head over to Instagram if you would like a tutorial on how to get these CEUs. So anyway, what are we talking about in this episode, Randy?
Yeah, so we are going to describe what pain is and how it affects student athletes, people moving in pain, basically, our active population. Then we're going to examine the detrimental effects of pain, especially those effects on human movement. And then we'll discuss some intervention strategies to treat the active participant in pain.
I think, like you were kind of mentioning, at some moment, each person has experienced some sort of pain in their activity.
Yes.
I think that's pretty safe to assume.
Yeah, for sure.
And what that looks like is probably different for every person.
100%. It's such an individual experience, which really leads into what kind of that definition of pain and kind of the most accepted definition for that is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So kind of like the individual experience is definitely the emotional component, right? Everyone has their own association with pain.
I like that you and I kind of picked out different pieces of it. Like you tied up on the emotional experience, but the thing that stuck out to me was the potential tissue damage.
Yes, and this is why I love this definition, is because, yes, obviously when we talk about pain, a lot of people think of actual tissue damage, right? You sprain your ankle, you strain your muscle, right? There's actual tearing in tissue that causes pain. But if you just look at it that way, you can't really explain pain in someone with patellofemoral pain syndrome or someone with low back pain that their MRI looks completely clean. Right? How can you explain their pain if there's no tissue damage? So that's why, that potential tissue damage is such a key indicator, and it ties in with the emotional experience too. And that's why I really like that, because it does combine also the sensory aspect too. So basically, the reason this definition is so great is because it just really explains how complex pain can be in such a simple sentence.
Where did you get this definition?
Oh, it's a very widely accepted. So any of the articles that I was reading, they defined pain based on this. And I think it's accepted by the international pain research kind of stuff like that. It is probably the most accepted definition of what pain is.
Some cool fancy people who are good at putting words to concepts.
Yes. People who love pain. I guess.
Maybe.
Possibly.
If you are interested in the references, by the way, those are on our website. Check the show notes for those as well.
This one has a lot.
I imagine.
I spent summer kind of working on this one because I knew it was going to be a complex concept to try to put together.
Yeah, pain is not something to be taken lightly.
Yes.
So how is pain transmitted?
So if we're going from a classic kind of idea, anything with tissue damage kind of gives you a nice example of how pain can be transmitted, right? So, a tissue is damaged, right? This stimulates the free nerve endings of nociceptors, right? So the nociceptors are what let the body know, hey, something might be wrong, right? A lot of literature, and, there's a great book, the Explain Pain book, great textbook. I've started reading that does a really great job of explaining pain.
Mm-hmm.
But the biggest thing is to really put that divider between pain and nociception, right? A lot of people like to confuse them, but just because you have nociception, just because those nociceptors, those pain, quote unquote, pain nerves are firing, doesn't mean you necessarily have pain. So that's going to be something important. But essentially those nociceptors, so like your C fibers and A deltas, going way back to modalities class, right? They get stimulated. And then inflammation also plays a role because they can make those nerves a little more sensitive. And because there's more things happening around the tissue, like actual like fluid and molecules and all that stuff, it increases the pressure on these free nerve endings, which only pisses them off more. Right, so they send that signal to the spinal cord, and in particular, the dorsal root ganglion, which then gets transmitted to the brain.
That pressure is kind of like what I explained to my student athletes of when you have so much swelling in an area and you have a lot of pressure.
Yes.
When you are able to take away some of that pressure, it helps decrease that pain because of all the receptors that are taking that pressure and transmitting it to the brain as pain.
Absolutely. And then also the contents of that swelling, they send out chemicals that make those nerves very sensitive. So if you push them out of there, that can also help as well. Once it gets to the brain, right, this is where that concept of pain becomes complex. And this is where we actually get the idea of pain, right? Just because one particular nerve is firing doesn't necessarily mean, oh, that's causing pain. It's just letting the body know, hey, something's here, right? Your brain then has to interpret, what does something here mean? Does it mean, ow, that hurts? Or does it mean like, oh, this is fine? Right. So once that signal gets to the brain, it's going to go through many different pathways, right? And, we could talk a long time about the different centers of the brain that might be involved in pain. And a lot have been viewed as, oh, this is your pain center. But I think now a lot of the literature says like your quote unquote pain center involves many different centers of the brain, right? There are ties from like where pain would be like kind of detected, and it ties in with your emotions, or it ties into the somatosensory areas of the brain, or even the executive function parts of the brain. So basically the whole brain is involved in this kind of pain interpretation. And this is, like you said, pain is so individual. This is where it's individual. My experience of pain is going to be different than your experience of pain. And my experience and my athletes are going to be different, right? That's why like people like to knock the pain rating scale 0 to 10, 1 to 10. And like, I don't know. I think it's important because you're getting an idea of what someone interprets what's going on to them.
I think it's helpful to know that, for me, it's helpful to know their trends.
Yes.
As far as like the pain, like 0 to 10, if you started 7, how much can we get you down to a 4? Whatever 4 means to you versus 4 for someone else, right? But if like for me, it's helpful for like before, during, and after treatment. It's not as helpful to figure out an initial assessment, but if I know someone normally rates things as like a 7 out of 10 pain, then I know that's normal for them. Yeah. So I do see where you're coming from of that pain scale. You just can't really compare it to other people's.
Yes, like it's such an individual aspect, right?
Right.
Someone's 5 is probably someone's 2, and someone's 5 maybe someone's 10.
But also, you might have someone who says they're at a 10 out of 10 pain one time, but then they get injured with something completely different, and they're like, I didn't even know what 10 out of 10 pain was back then.
For sure.
If I would have experienced this second injury first, then maybe I would have rated that as a 7, knowing that this is really what a 10 is like.
For sure. And you know what? There's when I was a student, we found this great TED Talk. I can't remember what it's called, so I apologize. I'll try and find it, but I apologize. I can't remember that one to help share that. Yes. But it was a presentation on pain, and that was kind of like it was tying into just how complex like individual experiences are with like the concept of pain, because if you've never experienced something before and it is providing a painful stimulus, that pain might be like, oh my gosh, this really hurts. But if it happens the second time, then it might be like, oh, it actually isn't that bad. And your body kind of understands like, oh, this wasn't as dangerous as I thought it was. I don't need to send as much of a signal, or I don't need to interpret this signal as really bad.
I mean, we talk about it all the time, like, oh, this is the athlete's first injury.
Yeah. Mm-hmm.
You see that all the time. Also, kind of in the sense of that, when you are interpreting time, I heard that, let's say you spend a year, your first year doing something, and it feels like it's super long.
Yeah.
But then you do your second year doing the exact same thing. Mm-hmm. And because you've already had a reference point of what a year long is, then the next year feels shorter.
For sure.
Because you already have an understanding. So kind of like where that pain is.
For sure.
Along the same lines, same thing like when you are training and you're, just starting to lift again from, however long you took off. And then the first like bicep curl, for example, like that you're doing.
Yeah.
Your body is actually not making physical gains. However, your body is getting used to that movement again. So you're actually your body is able to, I wish I had better words for this, better able to handle that weight.
Yes.
So even though you are not creating muscular gains, measurable gains, you're still able to withstand greater weight.
For sure.
Because of your brain.
Yeah. And we'll kind of talk about this a little bit later on, like kind of like what can we do about pain. Mm-hmm. But that concept of like, oh, like experiencing another painful stimulus and oh, it's not as bad is kind of like, that there is evidence behind that where like, oh, if you're having pain and then you introduce another kind of painful stimulus, right, it actually decreases the level of the other pain. Right, it's kind of like a conditioned pain modulation because your body's basically anticipating like, oh, like, okay, maybe this isn't as dangerous, right? Or there's another spot going on in the body. This signal is starting to get dampened, right? So that's another idea behind it. So that, like you said, like, oh, they're experiencing it. They're getting conditioned to that kind of stimulus because like, oh, I lived. Nothing bad really happened, or tissue didn't necessarily get damaged, or it wasn't as bad as I initially thought body-wise. So yeah, good, nice little segue again.
Going back into what you were talking about with the different pathways of like emotions and senses and executive function, kind of those three pathways, you can kind of also think about like within those like emotions, you can connect like emotions with pain. Yes. We've all had painful emotions or painful senses, obviously. Executive function, you can link all of those with pain. So It just goes to show, like I meant to say this earlier, but it just goes to show like how pain is just integrated in so many different ways.
For sure.
And that's probably why it's all over the brain.
Yeah, for sure. And why, like in studies that have done like, looked at low back pain. Well, low back pain has been shown to increase like symptoms of, I think it's depression, like depressive symptoms, and vice versa. Having higher levels of depressive symptoms makes low back pain worse. Because they're all tied, right? Those emotions are being tied with the pain as well. So yeah, absolutely. Tying in like kind of like again going with like understanding like pain is so individual, right? You really see it in our athletes, right? And it's no surprise that athletics or just being physically active, right? Just like physical active work, physical activity in jobs, right, is not a pain-free experience, right? It's not 100% pain-free. I think some of my athletes wish that it was, but it isn't. Right? It's going to be an uncomfortable experience,
right?
And we see it time and time again that athletes do tend to play in pain. Again, to varying degrees, right? Some feel they're probably more in pain than maybe someone else would consider, but in general, right, some of them do have to kind of play through some amount of pain, right? And there are a lot of factors that affect an athlete's decision to play with pain.
Sorry, the very first thing I can think of is just how much also a coach has a part to play in how much an athlete is playing in pain.
For sure.
But also on the opposite, like negative, positive, how much a coach is able to show an athlete that they can withstand pain.
Yes. And also not compete in pain too.
Right.
There are some coaches who don't really want their athlete to for various reasons. And there's and there are times where it might be somewhat appropriate for the athlete to play in pain. Now, we're not talking like they can barely walk kind of pain. We're just talking about, again,
let's just grind the rest of that knee cartilage that's left. Let's just get rid of it.
But remember, pain is just an unpleasant sensory and emotional experience, right? So it's something unpleasant. It's not saying like they can't walk.
Right.
I mean, that is an unpleasant, but you know what I mean. All right. And I think this kind of ties into, again, the individuality of pain is, there was a really great study on kind of understanding why athletes play in pain, like understanding that decision-making process. And honestly, in the sample of athletes that they chatted with, a lot of them were unsure if they were just sore or if they had an actual injury. So they didn't know what like the level of pain they're in. If this, am I just sore? Am I actually causing an injury, or like am I actually injured? Right. So a lot of them just kind of didn't know. So like if you don't know and you're kind of like, well, maybe this is just what soreness is like. You're not just gonna be like, oh, I'm sore. I'm not gonna. Sorry, I can't play in the final today. I'm a little sore.
I mean, I feel like if you don't know what soreness is, I feel like usually if I saw this a lot like in the high school setting, because sometimes that was like someone's first experience with regular sport, regular activity. I feel like if you don't know what soreness is, I guess it can disguise itself. Or I guess if you have never been injured before, it can disguise itself as soreness, vice versa. Yeah. I feel like there is a little bit instinct to it, but there's also a little experience to it. I feel like
which is, again, an emotional experience. Right? If you've never experienced before and things don't feel good and it hurts to move, you might feel scared and like, oh my gosh, like this hurts. I don't want to do anything. But then once you start moving with it, and then you're like, oh, this wasn't bad. Now the next time your body's like, that wasn't bad.
I wonder what leads someone to minimize the pain versus maximize.
Like, what do you mean?
Like, if someone has never experienced an injury before, minimize it thinking that it's soreness versus thinking it's more of an injury than it actually, quote unquote, actually is.
And you could kind of like, that kind of ties in with the kind of like some interventions for it, right? Because you can take a pain neuroscience approach to it, is like educating them on what pain is. And sometimes that helps with people. Like they kind of like, if you can understand, well, here's what pain is, here's how it kind of works. Some of them might be able to visualize it and take charge of it for sure.
I'm just talking about like standard, like if everyone had the same amount of soreness, like what would create someone's mind to tell them that it was more than just soreness or less than soreness? Like how much of an environment plays a role, how much of previous experiences plays a role, like those kind of.
For sure. And you know what? That does kind of lead into like kind of like what leads to maybe some difficulty in deciding whether to play or not. Like I said, sometimes it's pressure, right? Sometimes like pressure from coaches. And vice versa. Sometimes it's pressure not to play. Sometimes it's pressure to play. Or the culture of sport. Right? Kind of like just sport has this culture of, hey, you push through. Right? Good and bad, right? Sometimes it's good as far as like the soreness argument. Right? Hey, that movement is better for soreness. Right? You kind of want to push through. That's how you get your gains and stuff like that. But then on the flip side, like I got kids who could barely walk who were like, just take me up. Bro, it's a scrimmage. It's a long season, my guy. I gotta be out there. This doesn't even count for anything. So
it does to them.
It does to them, right? So like that just culture of sport. And then also there's the aspect of maybe like friends, family, maybe teammates, right? A lot of them have pressure. Oh, I don't want to let the team down, or I don't want the team to view me as weak, or like, that always happens. So some of that, like if they have those extra pressures, right? Maybe it creates more anxiety, increasing the pain, or maybe it gives them an avenue to like try and suppress it. So yeah, it is such an individual experience. Like it's really interesting to see. Another thing to consider about why people make the decision to whether they play in pain or not are future opportunities, right? We've come from places like the community college, the high school, where they're fighting for something, possibly like transferring or getting a scholarship,
just getting looks.
Yeah, getting looks, right? If maybe if they don't play, they don't get a look that day, or maybe they had a scholarship, but now they didn't play. Well, why are they missing time? Injury. Scholarship gone.
Right.
And that can impact someone's future, right? Another consideration, especially as we're starting to talk about like certain sports drafting out of high school or college, is draft position, right? If you have someone who might be getting drafted, that could cost them millions. Right? If there's an injury history, that's the difference from maybe being the first overall pick to maybe dropping down to 10 or not even in the first round. Right. So, all those do play a role in an athlete's decision to play, and also your decision as a clinician to say, should this person play or should they not? Again, just so individual. But even if the decision to play is made, there are some consequences when you play in pain.
No one wants to hear this part.
It is a part of the informing part, that just informed decision-making aspect.
I'm not talking about people listening to this podcast. I'm talking about when you take an athlete out and the coaches or the athletes, they're like, I don't care about what happens. Like, I care about the now.
Yeah.
Are we going to win this game or are we not?
And you know what? I mean, granted, this was before, like this was when I was working with track, so not quite the same as like a team sport atmosphere, because that is a difference, right? But in individual sport, I had one athlete, a multi, that was having some Achilles tendon pain, and like we were kind of in the middle of season, so it's kind of like, shoot, we don't have a lot of time to get you ready. Conference, which again, in like track, like that's the part that's scored. Like this is where it's going to be a big deal. And I was letting her know, like, hey, I think we need to take time with this, get this to calm down so we can prep to make your conference like really good, get you healthy by then. She didn't want to, and granted, it was her senior year, so she really wanted to do everything. And that decision was made that she kept going, and unfortunately it really kind of broke down to the end of the year where she didn't really have a great conference, and she looked and she was like, I should have stopped, Tom. I had no words. I was just like, it was your call. It's just that was the decision you wanted, and that we had to work with it. Well,
just because the outcome was the way it was doesn't mean it would have made a different call.
For sure. That's why it was your call. It wasn't right, it wasn't wrong, but those were the consequences of whatever decision was made. Just and vice versa. Maybe it would have went a different way if a different decision was made, or maybe not. So life's about choices.
It would have been a regret the opposite way.
It could have
possibly.
It could have been. Right? So that's why it is such an individual experience. But it does tie into, there are consequences to what decision's made. And if you are, the consequences of continued pain, there's one idea of peripheral sensitization. This is seen with kind of injuries with inflammation. This is kind of like the acute explanation of why things just starts to increase in pain. Right? It, like we said, it just that inflammation and the mediators that are there that are releasing chemicals, it just makes those nociceptors more sensitive. Right? So this isn't necessarily something that really describes the long-term consequences, but you could see it if you have someone who's kind of pushing through an injury that constantly keeps swelling or is dealing with inflammation. This can play a role in why their pain just is increasing or not going anywhere. But the big ones for long term are going to be your central sensitization. So this is basically the nociceptors in the central nervous system become more sensitive. Right? So this is the spinal cord up into the brain. And basically, as these neurons continue to get stimulated, they start to tie in with other neurons that kind of represent like a little bit broader of an area where the injury's at. So now they're creating a larger pain interpretation. So they're making the area of pain larger, even though that may not be where the tissue damage is or where the potential damage would have been. So this is
they're recruiting.
Yes.
'Cause misery likes company.
Exactly. So this is kind of like your situations where you have someone with patellar tendon pain, and then all of a sudden it starts expanding to like anywhere away from it. Like they start pointing at random spots like, oh, now I kind of feel it here, or like it hurts here and here and here. And you're like, whoa.
Well, that's also when you see like the clinician start to get really frustrated with whoever they're working with, because, you know, their pain is moving, and then it's just creating this like distrust between both parties.
Yes.
Which in reality, it's probably just because that's how the body's responding.
Yeah. Now the brain, because the pain has been stimulated so long, or that area has been interpreted in pain, now those neurons are recruiting other ones to broaden that area. So yeah, it does create just that kind of moving pain, or just a larger area than what it was before. And then another, I think a big one as kind of rehab professionals really need to take into account are the motor changes. Even the motor system is going to change when we're in pain, right? And we move differently when we're in pain, right? So,
this is what we talked about in the beginning.
Yes. So again, the idea is, hey, we're trying to protect ourselves, right? Our body's trying to let us know, like, hey, you stop hurting this structure. I need a break, right? So it's going to move a little bit differently to try and protect tissues. And what the body will do is it'll kind of change activity between muscles, right? So certain muscles may become like turned off, like deactivated, while others might get overactivated. They might turn on a little too much, right? And even the activity within a muscle may change, right? So the body's going to stop recruiting certain areas within the muscle and maybe stimulate other ones. Right, this kind of explains why when you have like someone with like a certain muscle pain or patellar tendon pain, and like you do a manual muscle test, but it's like, it's pretty strong, dude. Right? The force output's the same, but the way the muscle's doing it is different.
It's a really good point when taking into consideration what's really going on. The way that I explain this to my athletes is, we talk about all the muscles working together, because they're usually like in school, right? They're student athletes. Yeah.
Some of them like to think they're athlete students.
Yeah. Yes. But I talk to them about their muscles working together on a group project. Obviously, no one likes working on a group project because there's always going to be someone who is working more and someone who's working less, right?
Yes.
So what we need to do is take that person or take that muscle who is working more and send them on vacation, or just relax them a little bit, kind of take off some of the pressure.
For sure.
So then the other one is forced to step up and do the work that they're supposed to be doing. And then the other one can come back and they're in harmony. Yeah. That is our goal. That is usually how I explain it.
Yeah, for sure. That's a great way of explaining it, right? So basically all these changes in activity then change how the muscle mechanically functions, right? The way the muscles kind of pull on the tendon, or like the fascia around it, how it's being pulled, like the actual mechanical changes, or the mechanical like properties of the muscle kind of change just a little bit based on just how the activity has now changed. And all of this leads to that short-term idea of the body trying to protect itself. But if this becomes the pattern in the long term, this is where you're going to start seeing damage. And this is the explanation for why, one of the reasons why previous injury is such a high risk factor for future injury, because these adaptations in the long term are going to create either like faulty movement patterns to where something else is breaking down, or only promoting an injury risk to that same spot that was already injured.
I think we need to say that again. This is huge. So many people, including myself, obviously, I think this is just in general, don't have enough time or don't spend enough time figuring out what the actual cause is of why an injury occurred.
Yes.
And even if it's not why an injury occurred, like let's say it's a contact injury. Now you have pain. Now your body's moving in a different pattern, right? So your body has to go back to some sort of homeostasis that is not in the painful movement pattern that is currently or previously in.
Yes.
That's huge.
It is. And it's why rehab is so important. And why it's not just, we're just strengthening it. No. We're trying to retrain the motor system to go back to the pattern it should have been doing. And to break the cycle of, I'm just trying to splint my body. I'm trying to protect a part of my body. Because if it stays in that, that's where things are going to start breaking down, because now it's no longer an efficient pattern.
This is when you talk about people who are like quad dominant versus hamstring dominant.
Yes.
Or like when they're landing from a jump and they don't activate their glutes and hamstrings early to land from that jump.
Or the dynamic knee valgus.
Right. And then you end up, you rehab them and you end up seeing the exact same injury because you got those muscles really strong in that area, in that joint or whatever you're trying to rehab, but you didn't address the fact that their glutes and hamstrings are not firing when they are supposed to.
Yes.
They could be very strong. They could be the strongest, but they are not firing when they're supposed to.
From a functional motor performance, they're not doing a great job. Because remember, like we've talked about in a ton of our previous episodes, all strength is the ability, the max amount of force you're able to produce.
Mm-hmm.
Right? That's what strength is. As you have known, in athletics, we hardly ever do that. Right? When you run, when you sprint, yes, you're producing a high amount of force, but you're not producing max amount of force.
I don't know what you're talking about. My athletes max every day.
They think so. They definitely think so. But also it's sustained. Right? So again, not strength.
Mm-hmm.
These kids. Right? So again, that's why the limitation on the word strength and why it's not the sole indicator of injury risk, and why you can pull up countless studies that have examined, is strength a risk factor, and it's always inconclusive. There's some studies that say yes, some studies that are like, not really. And I think it's because of that aspect, because it's the strength testing itself is already a limitation. Yes, maybe strength predisposes to like poor motor patterns and fatigue, and that is what causes the injury, but that is so many different variables that those studies looking at strength don't look at. So for sure. So that's one thing when we're really focusing on our rehab is we're trying to retrain the motor system to just function normally. And that also ties into, obviously, when we're doing our rehab, right, we want to try and train the motor system, but also one of the things we all try to do, decrease pain.
The moral of this episode.
Yes, right, because what put that motor system into a position to say, hey, this is bad. We need to do something about this. It's the pain. Right? So if we can also decrease pain,
mm-hmm.
we may be able to help that motor system adapt with our rehab, right? Because if this is the one thing that's always tough with like rehab is, okay, what's your threshold like on pain? Right? Like there's your tendinopathy studies that have shown that like, hey, they're going to be somewhat uncomfortable. And
mm-hmm.
that's very beneficial for the tissue. But what's that threshold on how much is pain is okay? You know what I mean? So I think that's where another philosophy comes into play. But if we're talking like people rehabbing in excruciating pain, how much are we really like affecting them? Like, are we truly benefiting the motor system or not? Right? That's the kind of the tough part.
Mm-hmm.
All right. So some areas that we can decrease pain might be able to help our rehab, and why sometimes you'll see someone get put on an anti-inflammatory and do rehab because we're decreasing pain and pairing it with rehab. Maybe we'll get to see some benefits. So some ideas to kind of decrease pain is modalities are great for doing this, right? And in particular, electrical stimulation, right? Does a great job with pain.
Why?
A lot of great concepts there. I'm glad you asked. Right? Some of it can go into the gate control theory, right? You're stimulating the mechanoreceptors in the skin. That signal gets to the brain. The brain's like, hey, I'm going to interpret this signal first. Let's turn off that pain stimulus. I only want to focus on this bad boy. right? And that's great for in the moment.
It's distraction.
It's a distraction, right? And it's great for in the moment pain, which another thing that I do like to do with this is, especially if you're not too worried about tissue damage, is having someone on like TENS and then maybe doing a movement that was what they associated with pain.
Oh, I have never. Wow, this is like a mind-blowing moment. I know I've seen people who've done TENS with movement.
Mm-hmm.
I have never even thought to incorporate that in my practice.
Yeah.
You heard it here first.
Yeah.
Do you do that? Do you do that?
Yeah. Can
you give me an example?
Yes, I've had like a hamstring strain to where like, okay, we're getting to a point where like he should like this athlete should be able to start getting some range of motion.
Mm-hmm.
And I'm not too worried about the tissue damage because like we're going into a shortened position, right? It shouldn't be too crazy.
Mm-hmm.
All right. So I would put him on the TENS and then we would do
like sensory TENS. Yes. Okay.
And we would do assisted range of motion. So I would be able to push him further because he's not feeling a pain stimulus anymore. And we can get those gains. And, you know, possibly, I can't remember if I had him also kind of doing... Well, I did have... It was assisted. So he did have some activation. Mm-hmm. So now he's able to associate, oh, this isn't as painful. So then now when, hopefully the next session, he gets a little more activation. He feels a little more comfortable with it.
Mm-hmm.
I've done it for that.
I mean, I've seen like TENS on the low back, like people will walk around with it, but that's the extent of what I've seen kind of with.
Yeah, I've done that.
Uh-huh.
Or like have someone like have the TENS and maybe sitting's painful and have them in the sitting position with the TENS, right? Mm-hmm. So I've done that and I've seen some pretty good effects, like pairing it with kind of like just simple movement stuff. Mm-hmm. I've seen some pretty cool effects with that. And again, it's trying to trick the body into, oh, this isn't a painful experience. This isn't dangerous. I'm okay. And hopefully now
I know how to manage this previously painful experience.
Or I know how to manage it. So now the next time they're in this position, your body has a chance to interpret this as like, oh, this isn't as dangerous. Mm-hmm. Or the signal may be there, but the body's like, it's not as dangerous as you're making it sound. So then that pain level will kind of come down.
That's kind of the same... What I do with, like, for example, cupping for a hamstring, a lot of times I'll see the end range of like that hip flexion, knee flexion moment when like sprinting or like like when you're doing like a high knee.
Yeah.
Sometimes my athletes will say like, oh, this is where I feel like the tension because, or I guess knee flexion moving into a knee extension moment. Maximal hip flexion.
Yeah.
Moving into that knee extension. I will cup them standing up and I will have them move through that motion because that's the tightest spot.
Yes.
So that they are able to gain more length in the tissue.
Yes.
At that tight and painful, which tightness can also be interpreted
as
pain.
Especially if you have someone who either has never experienced tightness and they're like, oh, this seems like a problem, or someone who's had a long history of serious hamstring injuries, and when they start to feel tight, they're like, oh my gosh, this is really bad. All right. So it could go both ways. So you're right. That also ties into the manual therapy aspect. Manual therapy has been shown to decrease pain and may have some long-term effects, right? Kind of like that tension, right? Massage. Loosening the tissue can help. Massage can also push out those inflammatory mediators that could be causing issues. They stimulate the gate control theory because you're stimulating mechanoreceptors in the skin. But also from a joint mobilization aspect, right, has been shown to affect the central nervous system as well. And really, if you take a Mulligan course, this is exactly what they talk about as a proposed effect. Mm-hmm. Right? Right, they're putting some kind of mobilization on the joint, or at least the tissue around the joint. And the idea that they're telling us is that, well, the mob you're doing should like relieve the pain. There should be no more pain, right? And so they pair movement with it. So now you took the pain away with the movement. Now the body has a chance to learn, oh, this movement wasn't painful. This isn't dangerous. So now, theoretically, this could explain the long-lasting aspect of their pain relief, right? Oh, they took the pain away. Oh, that's not that painful. I can twist. I can do the weird things my athletes do when they say it hurts when I do this.
So you don't have to respond, well, don't do that.
Yeah, exactly. Right?
Just learn how to manage your pain when you do that.
Exactly. And that's, I think, the idea behind how Mulligan works is that idea. It's telling the brain that, oh, this isn't a painful, this isn't a dangerous movement.
Mm-hmm.
Back to...
This is specifically for when, going back to that original definition, when there's perceived tissue damage, potential, yeah.
But going back to the electrical stim real quick, because there's also a way with stim to produce endogenous opioids, right? So that can also help, obviously, with pain relief.
Which is not really the most fun.
No, it's not. But it, when you think about it, because in athletics, it's hard to do. Because again, a lot of these athletes play in pain, and you're not trying to shut that down, because some of them actually have some tissue damage that we're not trying to make worse.
Right. Mm-hmm.
But what if you have an athlete that's for sure out in a boot, right? But it's in pain. That may be an option to help maybe decrease some pain while they're already not going to be active. Right? Mm-hmm. So some options. Think about it. Modalities. Fun stuff. And then next, obviously there can be an education piece, right? Again, we're talking about an individual's experience. So educating them on just how pain works and, kind of understand why the athlete or patient views their pain the way they do. Get a perception of why they're feeling this, right? Maybe they're afraid, right? What other pain experiences have they gone through? All these things can really impact a patient's experience with pain. All right, so being able to educate them on again, the soreness person, right? If you've never experienced soreness, that could be kind of scary. Everything kind of hurts. What have I done? I think I damaged something, right? Educating them on you're okay. You're right. There's a little minor damage going on, but you know what? You're good. Right? Educating them on what is happening in their body. That can help some patients, some athletes feel a little more comfortable. Oh, okay. So maybe this isn't as dangerous.
Right. Unless you know that they're going to freak out over the word damage.
Yeah, exactly. You got to know your patients and athletes.
KYP.
Yes. And then finally, there can be a mental health component, right? Like we talked about, there are some pain conditions that are associated with mental health symptoms, right? So, right, keep an eye on these as well, because they may warrant a referral, right, to a mental health practitioner to help in that management of pain, right? If their symptoms of depression or anxiety are starting to increase, right, that could make the pain worse, right? So if we can work on those symptoms, right, that might help drop that pain down as well, right? And sometimes the mental health professional can help with them interpret their pain as well. Mm-hmm. All right. So again, interprofessional cooperation is really huge, especially when we're talking about chronic pain.
When you were reading, going back to this manual therapy portion, when you were reading, did it talk about anything about how just, how, I don't really know the words to say this, but how there's better outcomes. There's some things that say better outcomes are made when a clinician actually has contact with the patient.
Yeah. Not that I remember reading. I'd be interested on that too.
Further research is needed.
Yeah. I would be interested on that too. Also, one thing too that I've thought about is I do soft tissue with gloves now. Mm-hmm. Because just after COVID and just, I don't know, it's nice. I don't know. It feels nicer for me.
I don't like the lotion on my hands. It feels disgusting.
Right? It feels weird.
Yeah.
I don't like that out anymore. I used to go, no gloves, but now I do, and I like it. And I'm starting to think what role did maybe skin to skin contact have? Mm-hmm. I don't know. I don't know if there is a study on that.
That's a good point. Especially like like there'll be some people who like I'll do if I'm just like doing like cross friction, like I don't need gloves because I'm just using my thumbs or something.
Yeah.
But like if I'm doing like a milk massage or like effleurage or something like bigger, I usually don't like that much lotion on my hands.
Yeah.
But I wonder on the same person how much of an effect that has.
Would it make a difference? I feel like someone's had to have done this, but I don't know. It's just something I thought about because I'm like, oh, I made this switch. And I'm like, is that good or bad? It's good for me because my hands don't smell weird. They feel great after.
You just bang through gloves. That's a sucky part.
I do bang through gloves. But you see, that's why I try to be smart with them. Like a lot of times I'll one glove, right? Because a lot of times I'm just...
Yeah, right.
Because I use tools.
Yeah, tools don't need a glove.
Yeah. So a lot of times I just have the one glove to like just put the lotion on.
Oh,
and I try to use that hand with the tool. That's
also a good point. Tool versus hand.
How does the patient perceive it?
Exactly.
Because for us, theoretically, it's supposed to amplify what we're feeling.
Right.
So you feel the tissue better. Mm-hmm. Or like the actual adhesions or like dysfunctional tissue. Mm-hmm. But how do the patients feel about it?
And how much of that is us being a salesperson and having them buy in?
True. I mean, when I do manual therapy, I try not to, because I try not to like oversell it. I just tell them, here's what it's supposed to do.
We differ.
Like, here's how it works. Because I don't want to tell them like, oh, this is going to take it all away. You're going to be all good. Mm-hmm. And then they're like, the hell are you talking about? I still feel like crap.
Well, I don't tell them it's going to take it all away, but I tell them how great it is and why I love using this so much.
It's fair. That's fair. I don't know. I just like leaving it out to, hey, here's how it's supposed to work. And there will be so there will be times like, oh, like I've seen it, like it's done great with this, or like I'll educate them. Like I try to take away a lot of fears. Mm-hmm. So like with cupping, right? Because all the athletes like to be like, oh man, it hurts when you do this, right? And the kid who's never had it before is like, what? Oh my god! Like has the deer in the headlight looks. Right. And I try and tell them like, it's not that bad, right? It's gonna be a little uncomfortable. If anything, it kind of feels weird.
Right.
Right, it's just a weird sensation. And then you do it and they're like, okay, it wasn't that bad. I'm like, see, I told you.
Right.
Right, so I'll do that. But I don't think I've ever like said like, oh, this feel. Yeah, I don't know.
But here's the thing. Also, I feel like sometimes we glorify pain in treatments. Like someone having a hamstring pin and stretch, or a hamstring, like someone digging into their hamstring and saying like, oh, like that person who I was working with dug into my hamstrings like so much, like it worked so much because because the more they dug in, right. Because
they felt that discomfort, they felt like something happened.
Or they felt like the air quotes, they felt like they were breaking up scar tissue or whatever they believe
even
is
though
in
we
their...
know the truth.
Right. Right.
Yes, no, I know. I get what you're saying. Yeah.
So I feel like also like what if you do like a same hamstring, right? The first time you just do like a simple, just basic flushing. Yeah. And the second time you do like a real, like a deep digging, or opposite, like you do like some deep digging, some deep tissue, and then the next time you just do like a nice flush. Like how different are they going to think that it is affecting them?
Well, also too, another consideration again, because pain is so individual, you know, like the person who maybe that's their first time getting treatment. Mm-hmm. Oh shoot, I'm not trying to come in and like blow this kid up.
No.
Because I don't want them like scared.
You want them to come back.
Yeah, I don't want them to be like, oh, well, it hurts when I get this done. Why do I want to do that? So like, I don't know. I think that plays a role too. Like, I'm not trying to like, I mean, there are times, right? You're going to get sore from some treatments, or like some treatments aren't going to feel great. But like, maybe I don't do that one quite the first time, or or maybe we'll go like there's sometimes like if someone's like really nervous about cupping, but they kind of want to try it, like, okay, we'll go light. We'll just do it really easy, right? Just so they can see like, oh, this isn't scary. This doesn't hurt that bad.
Right.
Right. So like, it's also like doing tens. Like if you've never experienced tens, it's
weird.
It's weird and it's kind of scary.
Yeah, like, are you gonna shock me?
Yeah, are you gonna shock me? Or my kid who thought he's getting stem cells. Right? Like it's kind of scary. And then you kind of like explain to them like, hey, you're just gonna feel like pins in you. Let me know when you feel it. And then all of a sudden they start laughing because they're like, oh, I feel it. Like, I know. It's really cool, huh?
I feel like it's very fitting that we're ending this episode with a lot more unanswered questions because that's just how pain is.
And especially in athletes, it's such a fine line.
Is this your action item?
Probably. Like, it's such a fine line of what can they do in pain and what they cannot do.
Mm-hmm.
But no matter what decision's made, if there's pain present, we're balancing, okay, what are the long-term effects of that pain, right? Because, again, there's not, most time, there's not a right or wrong answer, right? An athlete has to do what's right for them, or a patient has to do what's right for them.
And not just right for them, like, that's not a blanket statement. It's not, it could be what's right for them one day, and then something the next day could be a different.
Exactly. Right. Like it's just like, you don't want to cost someone an opportunity.
Mm-hmm.
Right. So they may have to push. Right. It's the balance between, well, making sure it's not dangerous, but also, right, putting them in the best position as well. So, but no matter what decision's made, like I said, right, whatever decision made, there's going to be some kind of consequence that we're going to try and minimize, right? So how can we help kind of minimize that long-term deficit or detriment because of pain?
Mm-hmm.
And so you as the clinician with your patients, have that conversation of the risk reward and like, okay, what can we do to help kind of minimize the risks?
Because if we shut down everyone for pain, no one would be playing.
There would be no sports.
No. So again, if you guys are interested in this CEU, make sure you check the show notes for our most updated links. Thank you again to Clinically Pressed and Athletic Training Chat for hosting and sponsoring our CEUs. Our Instagram at AT Corner Podcast has a tutorial for you. If you guys are interested in other topics of our podcast, we do also, this is an education episode. We do story episodes where we take stories from other athletic trainers all over and we synthesize them on one topic every week, every episode. And then we also have interview episodes where we bring on people to highlight a specific topic as well. Mm-hmm. So just be on the lookout for those differing types of episodes. If you guys are interested in joining our Facebook group, you can. Facebook.com/group/AT Corner Podcast. We have discussions every week on various topics of what's going on the podcast. So you can kind of hear from other clinicians, hear what other people are doing. Do you have anything else, Randy?
Nope, that was perfect. Thank you for helping us showcase athletic training behind the tape. Bye.